Be starting with the revision of respiratory system. So in respiratory system, so I'll be covering your respiratory system in 2 to 3 classes. Before going to the individual topics, I'll not go into the individual topics in details. Rather, I will just uh, discuss the topics in brief, which are only important for your exam purpose only. So, which are the important topics which you must know in respiratory system are pulmonary vascular disease. Under pulmonary vascular disease, ARDS is the most important topic. ARDS stands for acute respiratory distress syndrome. This is important because nowadays we have been hearing lot of COVID infections, and you know one of the complications of COVID infections is ARDS, that is acute respiratory distress syndrome. So that you have to know a little bit. It may come as a short note at best for you. Then pulmonary infections. Pulmonary infections, the important topic under pulmonary infection is pneumonias. So pneumonias are the topic which may come in theory as well as in your vivas also. The examiners love to ask about pneumonias, especially in your vivas. Then come your COPDs. COPD is another topic which you must know in details. So what does COPD stands for? COPD stands for chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease, and under COPD comes 4 topics. These are chronic bronchitis, emphysema, bronchial asthma, and bronchiectasis. Now COPD is the topic which you have to know in little bit of details, because any of this topic under COPD, that is chronic bronchitis, emphysema, bronchial asthma, and bronchiectasis, may come as a short note for you. These topics are very popular for your exam purpose. Theory also, as well as in Viva also, they ask these topics. Then comes your chronic restrictive lung disease. Under chronic restrictive lung disease, the important topic is pneumoconiosis. So pneumoconiosis is a topic which is important from the point of view of your theory only. Usually they ask in theory. And then lung tumors. Lung tumors is again a topic which you have to know little bit in details. So basically, these are the must-know topics which you have to know from your respiratory system. These are ARDS, that is acute respiratory distress syndrome. Under pulmonary infections is pneumonias, COPDs, that is chronic obstructive pulmonary disease. The 4 topics, that is COPDs, are basically classified into 4. That is chronic bronchitis, emphysema, bronchial asthma, and bronchiectasis. So COPDs are important. Then under chronic restrictive lung disease, pneumoconiosis, that is the occupational lung diseases. Pneumoconiosis are the occupational lung disease which may come as a short note. Then lung tumors. Lung tumors is again a topic which usually comes in your theory. So basically we'll be covering these topics in brief in 1 or 2 classes. So today I will start with your lung tumors in very brief way, the important points which you should know. Even if you can't go too much in details, at least you should have a very basic idea about the lung tumors. Lung tumors, so in today's class I will only go through lung tumors only. Okay, in very brief. These are the important or the must know points you should know about lung tumors. In your, if you, I don't know which books you follow, if you go through Robbins or your any other book, they will write pages after pages about these topics, which is okay. It is good if you read them, if you can able to read them and digest them and remember them. But there are certain points which you must know, and that if you know these points, it is more than enough. So in lung tumors, basically they are classified into broadly into 2 types. One is squamous cell carcinoma and second is adenocarcinoma. That is how we classify the lung tumor histologically: squamous cell carcinoma and adenocarcinoma. But clinically, when we give a diagnosis, the clinical perspective which matters are small cell carcinoma and non-small cell carcinoma. So because under the small cell carcinoma and non-small cell carcinoma, these are the broad classification which a oncologist expect. At least if you can't tell this is a squamous or adenocarcinoma, but we should be able to broadly say it whether it is a small cell or non-small cell. Now, how does this squamous cell and adenocarcinoma, this squamous cell and adenocarcinoma, both this comes under the heading of non-small cell carcinoma, and rest usually falls under the small cell carcinoma. Is it clear now? Basically, clinically, lung tumors are divided broadly into small cell carcinoma and non-small cell carcinoma. Under the non-small cell carcinoma comes the entities called as squamous cell carcinoma and adenocarcinoma. Rest, most of them comes under the small cell carcinoma. So that is the basic funda of classification of lung tumors. If you know this much, if somebody asks you the classification of lung tumors and if you say this much, it is more than enough for you at your level. Now, why does it important to divide, clinically lung tumors into small cell and non-small cell carcinoma? Because there are two important things. First thing is prognosis of these tumors. Out of small cell and non-small cell, small cell carcinoma has poor prognosis. Small cell carcinomas has poor prognosis as compared to non-small cell carcinomas. So number one is poor prognosis of the small cell carcinomas. And number two is treatment. The treatment of small cell carcinoma is only chemotherapy and radiotherapy. Only chemo and radiotherapy. Whereas in non-small cell carcinomas, the treatment includes surgery along with chemo and radiation therapy. Clear why it is important to clinically differentiate between these two tumors? Number one, prognosis, and number two is treatment. Prognosis, because small cell carcinomas has poor prognosis. Treatment, small cell carcinoma, the treatment is chemotherapy and radiotherapy, no surgery. Whereas in non-small cell carcinomas, it is a combination of surgery along with radio and chemotherapy. So that is the basic difference between small cell and non-small cell carcinomas. And under the non-small cell carcinomas comes these two, squamous cell and adenocarcinoma. If you can able to, when a biopsy is sent to us and if we are able to say it is squamous or adenocarcinoma, then it becomes pretty easy for the oncologist to, approach with the case or treat the case. Now, there are certain points about small cell and non-small cell other than prognosis and treatment. That is, small cell carcinomas present with paraneoplastic syndromes. Do you remember paraneoplastic syndromes from your general pathology? If you don't remember, please read it today. What is paraneoplastic syndrome? Paraneoplastic syndrome itself is a short note for you from general pathology part. Okay, from neoplasia chapter. So what paraneoplastic syndromes basically are syndromes produced in some tumors due to production of some ectopic hormones. Due to production of certain ectopic hormones which are produced in certain tumors, and because of this production of this abnormal or ectopic hormones, they produce some kind of symptoms or some kind of signs and symptoms in those cancer patients. For example, this is a very good example, like small cell carcinoma of lung is a very good example of paraneoplastic syndromes, because they produce certain ectopic hormones which causes Cushing syndrome, hyponatremia, hypocalcemia, acanthosis nigricans. There are so many. Actually, this is, if somebody asks you, give an example of a tumor which causes paraneoplastic syndrome, your answer should be small cell carcinoma of lung, because this tumor produces the maximum number of paraneoplastic syndromes. They produce lot of abnormal hormones. This tumor produce lot of abnormal hormones. So that is one another important difference. Whereas non-small cell carcinomas usually doesn't produce paraneoplastic syndromes. So that is clear. So small cell carcinoma versus non-small cell carcinoma of lungs. So once you have crossed this step, okay, small cell versus non-small cell, then once it is a non-small cell, we want to know another step, that is this one, that is histological classification, whether it is a squamous cell or an adenocarcinoma. If you can tell this difference, that it becomes very easy for the oncologist to treat the patients further. Now, what is the difference between squamous and adenocarcinoma? Squamous cell carcinoma histologically will show, yes, what histological features of a any squamous cell carcinoma in any part of our body. It will have malignant squamous cells, it will have keratin pearls, it will have all those features of a malignant squamous cells. Whereas in adenocarcinoma, it is the histological features would be abnormal glands, and this abnormal glands will be lined by malignant cells. So squamous cell carcinoma arises from the squamous lining of the lung, whereas adenocarcinoma arises from the glandular epithelium of the lung. As you already know the normal histology of lung, it has both squamous lining as well as columnar lining. The tumors arising from squamous lining are squamous cell carcinoma, and the tumors arising from columnar epithelium is adenocarcinoma. So squamous cell carcinomas usually are hilar in location. Hilar means the portion that is the hilum of the lung, where the bronchus of the lung enters the lung, that part that about the hilum. So usually squamous cell carcinomas are hilar, that is central in location, whereas adenocarcinomas are peripheral in locations, that is they usually arises in the periphery of the lung, that is from the alveolar epithelium. Lungs has alveoli, right? So if the tumor arises from the alveolar epithelium, which is lined by columnar to cuboidal epithelium, so those tumors gives rise to adenocarcinoma. Whereas the bronchus, which is inserting into the lung, they are usually lined by squamous epithelium. So if a tumor arises there, it is a squamous cell carcinoma. So location differs. A tumor, if you see in X-ray a mass arising in the hilar region of lung, you will suspect it is squamous cell. Whereas a tumor, if you see in the X-ray, you do an X-ray and you see a mass arising in the periphery of the lung, it is a peripheral, it is a adenocarcinoma. Okay, usually the squamous cell carcinomas are common in men. It is usually common in men, whereas adenocarcinomas are common in women. So that is another important difference. Although it is not absolute, but it is in general practice we try to guess what tumors could be. If it is a man who comes with a hilar mass, we suspect it to be a squamous cell carcinoma, and then we do a biopsy and prove it. Similarly, a woman coming with a peripheral mass in the lung, then we suspect it to be an adenocarcinoma, we do a biopsy and prove it. So another important difference between squamous and adeno is smoking. Usually smoking is associated with squamous cell carcinomas, whereas smoking is not associated with adenocarcinoma. It is chronic scarring due to anything. It might be a old tubercular scar or scarring due to any cause, or if there is a chronic scarring in the lung, these scars give rise to adenocarcinoma. Usually these are not associated with smoking. So basically squamous versus adeno, squamous is common in hilar region, adenocarcinoma is common in peripheral region. Squamous cell carcinoma is common in men, whereas adenocarcinomas are common in females. Smoking is usually associated with squamous cell carcinoma, whereas chronic scarring is usually associated with adenocarcinomas. So clear everybody the lung tumors and the characteristics of this lung tumors. Clinically, what matters for the clinicians or an oncologist is small cell versus non-small cell carcinoma, because number one, prognosis differs, number two, treatment differs. If it is a non-small cell, small cell carcinoma is an entity by their own. It has no further subclassification. But non-small cell carcinoma is further subdivided into squamous and adenocarcinoma. And the difference between squamous and adenocarcinoma, I have told you, one is hilar, adeno is peripheral, squamous is common in men, whereas adeno is common in women, and smoking is associated with squamous, whereas scarring is associated with adenocarcinoma. So this much is the basic information or basic thing which you have to know about lung tumors. Suppose, now what are the symptoms of a patient of lung tumors come with? Usually it will be an elderly male or an elderly female. Usually it is elderly male or a female who will come in your OPD with symptoms of chronic cough, chest pain, dyspnea, hemoptysis. You know what is dyspnea? That is loss of breath or lack of breath. They will say, I cannot breathe properly. Hemoptysis, they will give history that they are vomiting blood. Okay, and hemoptysis is vomiting blood from the respiratory system. Then this elderly male or female patient, you will take a detailed history, whether the important history are smoking history, male, female, of course, that you will take, duration of these symptoms. Okay, once you have done this evaluation, you will, first thing you will do is to send the patient for an chest x-ray. Chest x-ray is the basic minimum investigation which you will do for lung tumor, not just lung tumor, any patient who comes with lung symptoms. It could be lung tumor or it may not be a lung tumor. So first thing, if you see, other than the mass, in lung tumors, the characteristic finding would be a lung mass in x-ray. And if you, even if you can't detect in x-ray, you will go for CT chest, that is computed tomography of chest. And what you will see, you will detect a mass. Either the mass is in hilar in location or peripheral in location, or it might be a mixed location also. The mass could be so big that you don't know whether it is from hilar region or it could be from peripheral region. So whatever might be, you will see a mass. That is the finding for any lung tumors. So along with the mass, you will see other features like features of pneumonia, features of lung abscess. Pneumonia and lung abscess, that happens as a secondary, secondary to this lung mass, because this lung mass causes obstruction to the respiratory tract. So whatever pent up secretions, they get secondarily infected, causing localized pneumonia or pneumonia around the mass, or it may form a lung abscess. So if a patient will have pneumonia and abscess, the patient will also have fever along with it. And also you will find symptoms due to distant metastasis. If the lung tumor has gone metastasized to brain or to liver, so you will find symptoms related to brain metastasis or liver metastasis. So basically, when a patient comes with any lung symptoms, the first investigation what you do is a chest X. You clinically evaluate the patient, you write all your history taking. Second, first thing investigation, you do a chest x-ray. If chest x-ray is not sufficient, you have to go for CT scan. And once you have detected a mass in the lung, you will go back. You want to know what tumor it is, no, because your treatment will depend what type of tumor it is. So what you will do, first thing you will do is the FNAC of the lung, if it is possible, or best is to do a biopsy of the lung. So once you have done a biopsy of the lung, we will tell you whether it is a small cell or a non-small cell carcinoma. And if it is a non-small cell carcinoma, we will tell you further whether it is a squamous cell or an adenocarcinoma. Based on this finding, this biopsy report, then you will start your treatment. What are the treatment options? Before starting the treatment options in a lung tumors, you will tell the patient that your tumor is a small cell carcinoma, your prognosis is poor. You have to explain the patient that prognosis is poor. But if it is a small non-small cell carcinoma, you will say we will try our best to treat you. The prognosis is relatively better as compared to other types of tumors of the lung. You will explain the patients about the prognosis, and then you will start your treatment. If it is a small cell carcinoma, you will give chemo and radiotherapy only, and you will explain the patient that it's a poor prognosis. The patient will, you will just there is some calculations of calculating how about the survival, 5-year survival, that this much chance of 5-year survival, 30% chance of 5-year survival, for example, I'm saying. And if it is a non-small cell carcinoma, then you will consult an oncosurgeon. Then in oncosurgeon will decide whether the tumor is operable or not operable. If it is an operable, in case of a non-small cell carcinoma, the patient will, the surgeon will operate the lung tumor along with chemotherapy and radiotherapy. So you will decide your treatment and prognosis. You will explain the prognosis to the patient beforehand based on the diagnosis you have got from pathology, and then you will proceed with your treatment accordingly. So this is about lung tumors. You know, I have told about the lung tumors in 2 slides. If you remember this much, it is more than sufficient for you at your level. Okay. So I will stop with this lung tumors. Lung tumors is a topic which may come as a short note. They may give you a long question also, and they will ask you in Viva also. So lung tumors you have to know. So lung tumors, what kind of clinical based questions can come from lung tumors? A question will come like this. A 60-year-old male presented with chronic cough, chest pain and fever. On chest X-ray or CT scan, a lung mass is detected in the hilar region. On taking history, he was found to have history of smoking for last 10 years. So what is your diagnosis? Okay, what is your diagnosis? Then your answer would be squamous cell carcinoma. Similarly, a question may come like this. A 60-year-old female came with chronic cough, chest pain and hemoptysis. On CT scan, she had a mass in the peripheral lung. There was no history of smoking. The patient did not give any history of smoking, but the patient gave history of a TB 25 years back. 25 years back, there was history of TB for which she took treatment. So what is your diagnosis? The diagnosis here would be adenocarcinoma of lung. So why I have given the history of TB? Because TB, even if it heals, pulmonary TBs, even if it heals, it may cause scarring of the lung, which may give rise to tumors in future. So this kind of applied question may come for lung tumors. Similarly, for small cell carcinoma, these squamous and adeno are non-small cell carcinoma, but small cell carcinoma is again an entity of their own. So a question may come, a 60-year-old male or female came with history of chest pain, chronic cough and hemoptysis. On chest X-ray, the patient had a lung mass, and he or she also had symptoms of Cushing syndrome. Okay, Cushing syndrome. When you see this word Cushing syndrome with a lung mass, that is, the patient is having paraneoplastic syndrome, and paraneoplastic syndrome is very, very specific to small cell carcinoma of lung. So this kind of questions, applied questions, may come in your exams. Okay. So we will continue with your revision class with pneumoconiosis tomorrow. So even if you remember this much for lung tumors, it's more than enough. Okay. So this finishes your class.